What I enjoy most about securing the airway is the level of critical thinking involved in doing so. We have a number of tools at our disposal in order to secure the airway, and there are many different patient factors that determine which tools we use and when it is more ideal to do a different technique or intubation method, or whether or not to intubate at all and use an alternative method of securing the airway. On the other hand, what I find challenging about securing the airway is that each and every patient is different. What works for one patient may not necessarily work for the next patient, and you have to be able to utilize your training and your skills in order to maintain a level of focus required to secure the airway. Also have to be able to step back, zoom out, look at the bigger picture, and reevaluate what the best method is for securing the airway.
During the induction of general anesthesia, there are a few different tools we can use to support or secure an airway during surgery. One of the most frustrating things about using an LMA is getting it to seat properly and create a good seal, which can really challenge your troubleshooting skills. During induction, it's important to establish an adequate depth of anesthesia prior to airway manipulation, as this can produce a significant sympathetic response. In these critical moments, it's important to recognize that we're essentially putting our patients into a coma. I need to protect that trust instilled within us and always be mindful of supporting their airway, breathing, and circulation. We will often use video laryngoscopy in lieu of direct laryngoscopy when we anticipate the airway may be challenging.
Once the blade is secure, as seen here, we are able to pass the breathing tube into the vocal cords under direct visualization, potentially reducing the risk of airway manipulation and trauma. Nasal intubation is typically indicated in maxillofacial surgery. The first thing you want to do is use a nasal spray medication like Afrin, which acts on alpha adrenergic receptors of the nasal mucosa to produce vasoconstriction. Next, you will dilate the nares using increasing sizes of rubber nasopharyngeal airways. Progressive dilation of the nares is key in establishing patency and minimizing the likelihood of trauma. Next, you will take your lubricated nasal endotracheal tube, lifting the apex or tip of the nose and advancing towards the base of the skull into the lower pathway just below the inferior turbinate. Then with the use of forceps, you will pass the tube through the cords. This can be done under direct visualization, glide scope, or fiber optic technique.
Use ultrasound or the landmark technique. It's good to learn both. Sometimes the ultrasound might not be available, so you have to be good knowing that your nerve is most lateral, your vein is going to be medial, and then in between is going to be your artery, and just being good about palpating your femoral pulse when you do it. The nice thing about ultrasound is that you can visualize these structures. It's good to be doing both ways just so that you can get practice doing both. And if the situation arises, it's an emergent and you don't have an ultrasound, it's good to know how to place one just using your hands.
The site should be 1 to 2 centimeters below the inguinal crease and 1 centimeter medial to the femoral pulse. You can see on the ultrasound right there. Use the 18 gauge needle in your skin at a 30-45 degree angle. Once you get a flash of dark red blood, you thread the guide wire over the finder needle. Pull out the needle and make a little nickel scalpel. Advance the dilator into the skin, pull it out the dilator, and then thread the central venous catheter.
Being able to insert a central line is an important skill to have as a CRNA, especially in situations that require volume resuscitation, administration of pressors, central venous pressure monitoring, trauma anesthesia, and as a treatment option for venous air embolisms. One of the most common approaches to central venous access is through the internal jugular vein. IJ access is typically associated with a lower rate of catheter malposition and is much easier to insert given its direct route to the SVC.
Locate the apex of the triangle formed by the sternal and clavicular head of the sternocleidomastoid enclave. With a 25 gauge needle, inject 1% lidocaine into the skin at the apex of the triangle to numb the area. With a 22 gauge finer needle and 5 ml syringe, insert the needle pointing to the ipsilateral nipple, traversing along the lateral head of the sternocleidomastoid. Aspirate as you advance your finer needle until dark venous blood returns. Remove your syringe and insert your guide wire into the finer needle. Remove the finer needle while stabilizing the guide wire. Scalpel blade pointed upwards, nick the skin to allow smooth passage of the dilator. Insert the dilator over the guide wire into the subcutaneous tissue to facilitate catheter insertion. Then remove the dilator while controlling the guide wire. Insert the triple lumen catheter over the guide wire. Insertion depth for most adults should be 16 to 18 centimeters. Monitor for ectopy as you insert the catheter. Once at an appropriate depth, remove the guide wire, aspirate the ports, and flush each port with saline. Suture the catheter in place and apply steroid.
One of the things I love about regional anesthesia is how you can do a whole anesthetic with a good block. It requires a lot less opioids, it's a lot safer, so there's a lot of benefits to it. With that being said, it's also been challenging learning all the different techniques and all the different amount of volumes to give with each block. On top of that, learning which local anesthetics are appropriate for each different block.
Here I am using an ultrasound to do a popliteal block. You can see the common peroneal and the tibial nerve right there, and that comes together to form the sciatic. So first I'm going to localize and look at my ultrasound following the tract. Then I'll follow that tract with my peripheral nerve stimulating needle, aspirating and injecting local anesthetic. Similarly, I'll take an out-of-plane approach here at the sciatic nerve block, visualizing my tract with my local, and then I'm going to follow that with a peripheral nerve stimulating needle, aspirating and injecting around the sciatic. Here's a saphenous nerve block, and my landmark here is a femoral artery. You can appreciate my needle tip and how close it actually is to the artery. Injecting into any vascular structure could be detrimental to the patient, so it is important for us to have a good understanding of where a needle tip is.
Here I am doing a transversus abdominis plane block, or TAP block. With the help of ultrasound, we can easily visualize the 3 muscle layers and inject the anesthetic in between the internal oblique and transversus abdominis, carefully avoiding bowel perforation. We get to learn how to use the ultrasound to block the brachial plexus for shoulders and arm surgeries. For interscaling blocks, we are visualizing the trunks of the brachial plexus in between the anterior and the middle interscaling muscles. We are also able to scan down and see the divisions of the brachial plexus supraclavicularly. It's critical to properly visualize the nerves, to adequately deposit the local anesthetic, and to avoid puncturing the carotid artery or the internal jugular vein.
I enjoy doing spinals because they're a great alternative to general anesthesia, especially for procedures involving the lower extremities as well as urology procedures. It's nice to remind yourself of the spinal cord anatomy as you're doing them as a resident. I always say in my head the different ligaments and the different meninges as I'm going through with my spinal needle. It's a nice challenge because you quickly realize that everyone has a different anatomy and people will continue to surprise you.
So for a spinal, I want to aim for the L3 to L4 interspace. So I'm palpating the iliac crest to find that space in the midline of the spine. I'm going to mark that with my thumbnail so I don't lose it later on. I'm going to prep the back. While the prep is drying, I will drop all of my medications in the syringes, then put up my sterile drape on the dry back. Repalpate the space, and I'm going to localize the skin with a skin wheel and go all the way in to make sure the patient is comfortable. Introducer needle goes in. That's going to serve as a guide for my thin, flimsy 25 gauge spinal needle, which I will be inserting here. Now it's important to feel for your ligaments as you're advancing your needle. So the supraspinous ligament, interspinous ligament, the ligamentum flavum, the dura, and arachnoid mater. And then you're going to place the syringe with a local anesthetic. Watch for CSF swirl, which the barbotage is for.
and then you're going to inject all of it in, pull everything out together, and position your patient.
Epidural anesthesia can be used for other procedures, but it's mainly used in OB anesthesia. I love epidurals because it provides a relatively quick analgesia for laboring mothers. It's such a rewarding experience to see a mother go from writhing in pain to finally relaxed and resting in bed. This type of anesthesia can be pretty challenging, to find that sweet epidural spot, but I love the challenge and I can't wait to learn more and perfect my craft during residency.
When it comes to epidurals, positioning is key. You want chin to chest and back arched like a mad cat. You also want to keep everything completely sterile because it would be detrimental to get any bacteria into the CSF or meningeal area. The next step would be to localize the skin, and that'd be a quick pinch and a burn, and I would also use that as a finder needle. Then you would advance your toy into the ligament, remove the stylet, and attach your loss of resistance syringe. Slowly advance until you get your loss of resistance, right there. And then you would count your spaces, and then thread your catheter. I usually do 5 centimeters past the number on the 2A needle, but I advance the catheter all the way so it gives me slack as I slowly detract the 2A needle and advance the catheter at the same time. Make sure once the needle is removed from the back, that the catheter stays sterile. Slowly remove the catheter, there you go, and then pull back until you get to that number. Then it's test dose time. You want to aspirate before, just make sure you're not in vasculature, and then administer the test dose. And then you're done.
Oh, look at his eyeball. It is preoxygenated. I administered my
So we go deeper.
anesthesia and paralytic. Scissor the mouth open. Guide the blade in.
I mean, I'm gowned up. No one can tell me.
You can't look much.
Am I Luke or am I Nathan?
Ruins around here.
I see where it is, but
Hey, this is Rob here. Just wanted to tell you guys a couple things that I've found enjoyable while renal.
the reason I like femoral lines is that